Hi everyone, my name is Dr. Anthony. I'm a consultant in Diabetes and Endocrinology, and I also do acute medicine. I'm currently working at the University Hospital of North Tees and Hartlepool here in Stockton in the northeast of England. So this pandemic of coronavirus has given us an opportunity to look at our service. I happen to be the clinical lead for diabetes for the trust, and when we knew this was brewing, we were aware that it will have significant effect on our service. Delivery of our service, the care we provide to our patients, both inpatient and in outpatient, and crucially for those vulnerable patients in the community. We as a team consist of 5 consultants. We have multiple roles, 7 to 8 diabetes specialist nurses, and we have inputs into primary care where consultants go with diabetes specialist nurses and provide the service. In the community, providing GPs and practice nurses our expertise. Not only that, our consultants are involved in acute care where we take part in emergency admissions unit, and our specialist nurses provide an inpatient service. To give you a flavor of the breadth of the services we have, we run diabetes pregnancy clinics, we have pre-pregnancy clinics, we have acute foot clinics, acute foot MDTs, where orthopedic consultants, podiatry services work with us. We have designated ward rounds, designated foot clinics, and in a nutshell, a lot of services which are providing both acute essential diabetes care and also the bog standard routine clinics which are provided in hospital, in the community, and in GP practices. So we felt we had to look at the pandemic that was in the horizon coming to us to provide a service taking into account the new challenges that would come to us. So what I'm trying to provide today is a basis of how we structured our service, knowing the things that were brewing in the horizon, knowing that we had to work in different circumstances, have different challenges, knowing that our patients would not be able to see us face to face in clinics, knowing that our group of patients were highly vulnerable to the coronavirus, and something which we probably didn't take for granted initially was that our staff too will be affected by the virus, and that this was not just a short term but a longer drawn out process. The basic principle was keep it simple, and that I think is something I have learned over the few years I've been the clinical lead. You need to manage a team which is multifactorial, have multiple strengths, and you'll be surprised that there are hidden strengths that I think a good team leader and manager should recognize, and I think you should actively look for it. Crucially, you will also know that your team have got not so much strengths, and that is a time you will be pleasantly surprised that somebody you thought would not make a strong point suddenly steps up to the mark. So this is just a slight detraction from what I'm trying to say. But the overall point is keep it simple and set up plans that are simple, that can be easily evaluated, easily implemented. So taking that on board, I felt there are a few things that any team should have. There should be a nominated team lead, which most teams already have, and that is fine. Secondly, in the current crisis, I feel that you should anticipate that the current team lead or a team leader may not be there, and the virus strikes indiscriminate, as it was in our case. So you should have a plan B. In that Plan B should be a core team who somebody else can step up to the plate. So something to take for. So now coming to the more specifics of it. And I feel this applies to every team, and that is good communication. So your team member are there, you got your core set of team members, and then it is communication. And we have used WhatsApp, we have used email, but there is nothing to detract from a good face-to-face chat. And we got together a group of team members in a room with the social distancing guidelines in place, and we had a very good talk. And in that talk, we mapped out our plan. We mapped it out well. We knew what the challenges were. We tried to picture it mentally to see how this would affect us. And then, again, I come back to it. We kept it simple. We anticipated what the issues would be, and then we put it down to each level. So, information is the second part, I would say. We had to reallocate to areas which we knew would be affected. One thing which we found was, do not be afraid to seek help. There are various people willing to help, and I give an example for IT, where we went and sought help and they were able to provide us with help. Secondly, look at other team members in the community who will be more than happy in any crisis to come and give you that hand. So, in a nutshell, put your ego aside, ask for help. You'll be pleasantly surprised where people will help you. Finally, once you have anticipated, understood your team, what you want to do, disseminate the plans well. Disseminate it well, and again it comes down to what I have said. It is communication and information to provide that. Okay, so that's it. The next step, I feel, is you need to test your plan. It is all said and good to anticipate, put things into place and do it. I think there is nothing like a good test. Now, for example, you want to know how will the foot team work with PPE there. So test it out. Try and test it out either as a dry run. You can't do it with actual patients, but try and do it mentally. Speak with teams, the people who are at the coal face, to see if you can then roll it out. And you'll be very soon seeing potential problems and pitfalls that will come. So test the plan. Now, coming to specifically to diabetes, we put in place telephone clinics. We plan to do some video clinics. Telephone clinics has happened. We have been quite surprised. Patients are very happy to receive phone calls. But it is important that we look at it from a doctor's point of view. We are all so used to speaking to patients on the go that lack of human touch, I think, should not be underestimated. And I found it as a consultant. There was nothing to see the patient's eyes, the smile. You picked up so many non-verbal clues. That is, I think, lost in a telephone clinic. It is different from a patient you have known for 10 years. You are very comfortable. They are comfortable with you. But for a new patient, I still feel that you lost the lack of the face-to-face, I think, is essential. Now, it may change as the lockdown comes down, and I think that is something we have to evaluate. So we are hoping to have face-to-face in clean green zones, as we call it, where the risk of the COVID-19 is minimal. We hope to roll it out to those patients who can come, and I think we will be screening it and doubly screening it to make sure that it is essential that a face-to-face happens. Of course, there are those unavoidable face-to-face, like a new type 1 patient where we can't avoid. But we do have vulnerable patients who I think a good face-to-face discussion, interaction almost certainly has benefits over a telephone conference. However, for a vast majority that we are doing currently, it is doing pretty okay. So, one further point I would like to say is we have identified, and this is where the role of the diabetes specialist nurse is crucial, those vulnerable patients who we need to put that extra effort. It may mean regular phone calls. It may mean having that little extra bit of input, which I feel will go that little bit extra to ensure that they remain safe during this period of lockdown. We need to consider that the patients have got a lot of fears about the current virus, and it is for us to try and allay those fears, to try and dampen those fears. And there is no doubt that a good diabetes control makes sure that their mental health, their mental status remains better controlled too. So on all levels, it is important that we anticipate these things, knowing that our group of vulnerable patients need that extra input. So the second point, or the third point I would like to say, is coming back to our service. You need to feel, and this is what we did, is to understand the crucial services. We identified pregnancy in diabetes as one, so that has continued. Secondly, the high-risk foot clinic, which we felt could not be ignored. We could not do it over telemedicine. We need to keep that service going. There's nothing worse than having an ischemic leg that is 3 days old. Almost certainly the patient would probably not pull through. So that was one. Secondly, new patients with diabetes, new type 1s you cannot ignore, and pump clinics. Those were the 4 critical areas that we felt had to keep going. So that is where we have put into plan this service to carry on. And I'm pleased to say that we are seeing some good results. Something else which I come back to, and that is staffing and human resources, if you want to put it. In the current coronavirus, it is great that you know your team, you know your strengths, you know their not so strengths, and I say that we play to both of those. What we did not anticipate was the attrition rate. So suddenly we had 70% of our team falling prey to the coronavirus. And that led to a lot of initial resource allocation and problems. Again, I go back to it. When we lost so many team members, it was down to the basics. Which are the crucial services we need to keep going? And this is where there are members of the team came up, did more work, covered for each of the consultants and the specialist nurses who were ill. And I'm so pleased to say to be part of this team where there were individuals who stepped up to the plate, took on the roles that was demanded of it, and delivered. So crucial that we have a good, well-working, well-oiled team that gels without politics. So what I would say is this only happens if you have a team that has been working together for many years. You cannot suddenly expect a new team member to come and do it. They may well do, but it is a team that has known each other. And specifically to our team, I worked as a registrar in this unit. I know the team. Similarly, the team knows each other. We are gone beyond that level of just being colleagues. I think we are mutually respect each other, and that almost certainly helps. So a great team, no denying. Good members of a team is the essence of this being a success. Finally, I would say you should have a plan B for each team member, because if for some unknown reason that member is not there, there should be somebody else you know could slot into it. Now, if you can plan for it, great. But most situations, I expect you cannot plan for this. Your levels of people falling ill will be something you cannot plan for. Something I have found is to have a fast-moving team. So it may just be 2 people, but if those 2 people can move and work together and move fast, so going into multiple areas from their room using technology, nothing like it. So we achieve a lot by using technology, sitting in the office, sending out messages to those crucial areas where that service needs to be delivered. For example, patients have got coronavirus, they are in a corona ward. You do not need to put a full personal protection to go in. You could sit in your office, provide messages to the team that are at the patient, looking after them. The blood sugars go on to the IT system. We look at the blood sugars and we send messages out. So we do it virtually. the message goes across, we sit and evaluate, look at the sugars, make sure it is responding well. And if all that fails, then we actually go on to the actual physical presence on the ward to ensure that message is delivered and implemented. So that's that. Finally, I feel all the measures that you do, it is important that we evaluate it. It is no point setting up a service to do it, and it's great when it all happens and you know it is happening. But for me, data is crucial, and I feel as a team we should evaluate the service we're delivering. So put into place systems that you can evaluate your service, and that I think is crucial. Finally, it is about education and training. This should not stop us from educating and training the staff of the non-diabetes team, and that is, I think, is important. I go back to the analogy. Yes, you can buy fish and deliver it, but there's nothing like teaching a man how to fish. So you provide the tools that a non-diabetes team can then implement it. So I feel, in a nutshell, if somebody was to ask me to give a 2-minute sort of overview of how we have managed in the current crisis, I would say know your team, be confident of your team. The plans you are going to implement should be simple. The information that you are doing should be disseminated. You should have well-designated roles, and you should be confident that your team will step up to the mark. That comes with knowing your team. Finally, have systems in place that will evaluate the things that you put into place. And I think these principles can be applied to any managerial or any crisis.